have an online speaker. We're pleased to announce Alexander Jäkel, who is the chair of the Digital Health Working Group in the Standing Committee of the European Union, the CPME, and he's going to address the issues or the problems that face the doctor community in regards to EHDS, which was a perfect segue which Clara just gave us. So I don't know if he can come online.
Yes, good afternoon from rainy Berlin. I hope you can hear me.
Alexander, can you hear us?
I can hear you well. Can you hear me?
Hear you?
Can you hear me?
Yes, we can hear you now.
Excellent.
Go ahead.
Thank you very much. And a good afternoon, I think it's fair to say, at 12:30, good afternoon from rainy Berlin to you in Montreux. My name is Alexander Jäkel. In my everyday job, I work for the German Medical Association, whose building you can see behind me, but I also have the privilege to be the chair of the CPME Working Group on Digital Health. So, as you already said, it's actually a pretty perfect fit now that we have a look at the European health data space, a project that has been going on in Brussels for quite a while. And I would like to bring you the position on this European health data space that was drafted by the CPME, the Comité Permanent de Médecins d'Europe, so the European doctors. To give you an idea who I represent today, CPME is the umbrella organizations of the most representative doctors organizations from the European member states. 1.7 million European doctors from 37 countries. That means, of course, that it's not only European Union member states, but also countries like Switzerland, Norway, and many countries in Central or Southeastern Europe, which are accession countries, so which hope to be a member of the European Union soon. CPME organizes all kinds of doctors. So we have junior doctors, GPs and specialists. So we have a pretty universal perspective from the doctor side regarding different political projects, including the European health data space. As I said, the European health data space has been a certain buzzword in Europe in the last couple of years. CPME has been closely following the political developments over the last 2 or 3 years. We've had different policy papers regarding the idea of a health data space in the past, mainly regarding the ethical perspective. So the European health data space, at least in the perspective of European doctors 2 or 3 years ago, should not be a means to overrule certain ethical considerations doctors should have. But since we had the opportunity to look at the regulation that was proposed by the Commission in early May, we've had a, as I said, close look, and we've come up with certain general observations, some recommendations, and also some conclusions. And I would like to use the next, say, 10 to 15 minutes to walk you through our first reading, first understanding of the proposal that was, as I said, tabled on the 3rd of May. First of all, if we have a truly European health data space, a truly functioning European health data space, it will mean a big cultural shift for all parties involved. First of all, governments, and this is something that we've been hearing this morning, governments will have to make sure that the health data space works from a hardware, a software, and a training perspective. New authorities will have to be implemented, new legal tools will have to be developed, and also certain needs of the professions will have to be met by the government. So this also means a change of perspective on behalf of the governments, not least because they are leaving the national arena, and the European health data space, as the word says, is a more cross-border and European effort and approach. Also, of course, and this is important for us representing doctors, Doctors will have to change their daily work. They will have to provide more data to the health data space, also maybe data which they consider confidential and private. They will have to adapt their private infrastructure, so their practice infrastructure, I'm sorry. So they will have to see how their existing infrastructure fits into the data space requirements. It also means that they have to improve their own digital health literacy. I know especially younger doctors don't have any problems feeling at home, sharing data, using online tools. But many doctors, not only in Germany, where I come from, but many other countries, many doctors are rather at the end of their professional life, and they are not exactly digital natives, and they will have to learn how to use certain tools to share data in the European health data space. A change is also required for patients, of course. The old picture, the old relationship between doctors and patients has somewhat changed in recent years, and the EHDS will be a game changer for that as well. I mean, the old picture where the doctor is basically the leading person in a treatment scenario is no longer true. So the patient has become more and more involved as well. The EHDS foresees a clearer and more responsible role for the patient as well. Managing his data, sharing his data, also blocking his data. And this is something that patients will have to learn. They will have to learn what they should share, what they shouldn't share, what they should maybe block in certain different treating environment. This is all something that requires lots of work, lots of learning on behalf of the patients as well. And not least, also the industry has a big challenge to face, and I'm quite happy to be here to discuss this with you, because I believe this is something that you've been working on in the last couple of years. We need one standard to exchange data between member states and also between medical professionals. We have seen in the past that there were conflicting standards, and this is something that will impede the European health data space from working properly. Only if we have one clear standard to exchange data, if there's a clear and working interoperable system, then the whole data space, which we believe is a good invention, will have success. So from the no, this is still a general observation. Also, what we found in the proposal by the Commission in early May is a clear reference to telemedicine. Of course, telemedicine, not least because of the pandemic we've seen in the last 2 or 3 years, has been changed. I mean, telemedicine is here to stay, and we are not arguing that telemedicine should be excluded from the European health data space. We know the reason why the Commission included the reference to telemedicine in Article 8. But what we are afraid is that telemedicine as such is, as I said, a game changer. If you combine the game-changing effects of telemedicine and the game-changing effects of the European health data space, you might maybe ask too much from this development. And we are slightly cautious to have telemedicine included in this regulation. So a first summary from the perspective of European doctors: yes, we do feel that the European health data space is a really good tool, not only to enable patients to travel cross-border, not only for a medical treatment, but also for other reasons that then maybe feed back to a medical treatment. We feel that the requirements regarding interoperability must be much clearer. So the legal, technical, and semantic interoperability is something that we should have a look first. And only if this question is solved, we can actually have a look and hope that the system works in the end. And the other question, which is, as I said, more an ethical issue regarding doctors, there must be clear rules what kind of data can be shared by doctors, in which format they can be shared. So if they can be anonymized, or if there's maybe another form and format that data can be shared. So doctors are concerned that the European health data space might be a tool to overrule certain requirements that doctors have to obey regarding the privacy of patients. So this is something that we want to have a really clear message from Europe that this is not the case. So recommendations. There are there's a long list of things that we haven't seen properly addressed in the proposal that was tabled by the Commission in May, as I said. So first of all, what's the rule for minors and persons with disabilities? There isn't a clear rule how these special needs are taken into account when they are, or when the data is being shared during the European health data space. We haven't seen what we had in the past, a clear role and involvement of ethics committees. This is something that has worked in the past for clinical trials, for example, but also when it comes to accessing certain data of patients, the role of ethics committees isn't as clear as it has been in the past, and we would hope for a clearer ruling regarding the involvement of ethics committees, especially because the different national rules are so different. We need a clear rule when data of patients can be used for as secondary use. So when the data of patients can be moved in the European health data space for scientific reasons or for research. There are, as I said, so many different rules in the European member states. So we need a compromise, and we need a clear role for medical ethics. And we also need a clear rule that breaches of these ethical obligations for doctors are punishable. And last but not least, on this page at least, there's a long list of further recommendations coming up. We need to have a look how personal notes of doctors are taken or are incorporated into the European health record or the electronic health record. It is common practice for doctors to have written notes, written personal notes. Of course, this is information that might be important for doctors in another member state if a patient moves into another member state. We heard from the speaker before that some information is better than no information. But sometimes it's the case that too much information isn't good either. So we have to find a balance between sufficient information without being in danger of providing too much information. Another thing that we as European doctors are concerned about is the problem of possible re-identifying of patients. Of course, it's clear the more data you have and the different data sources you can use, it can be possible to re-identify a patient. We are happy that this has been taken into account by the Commission when they drafted the proposal, but we are concerned that maybe the punishment, if someone takes the effort or makes the effort to re-identify a person, isn't high enough. I know this is a member state competency, but we should still be clear that if someone really has the criminal intention to re-identify a person, a patient, this is something that should become a criminal offence and should be punished. We have also had a look at the problem of data quality. We know that there is, of course, a whole list of apps and applications that are used by patients in Europe, that these apps, of course, provide data, activity data, maybe dietary data. All this is, of course, data which might be important for a doctor and might be important for a research project as well in the health data space. But we call for a high quality of data, and for this, we urge the Commission to limit the scope of apps which can be used and which can actually feed data into the health data space to certified apps. So it shouldn't be a whole list of apps. Not any possible health app should be able to feed data into the health data space, but only those which have been certified before regarding or considering ISO standards. Also, and this is maybe the key point of the whole proposal, the secondary use. we need to find a way that only scientific research which is in the which helps contributing to public health should be accessible. So should be using data which has been provided by doctors, for example, into the European health data space. And of course, there should be a benefit as well. So it shouldn't be research for the own sake of research, but there must be a clear benefit for the public in order to gather or to be granted access to data in the health data space when it comes to secondary use. Right, maybe I can move to what we as doctors consider most important about the proposal, and this is again regarding the role of doctors. Doctors are supposed to treat and help patients. They're supposed to dedicate their time to their patients. What we are afraid of is that the introduction of the European health data space might change the role of a doctor to well, using too much of his time to feeding data into a system, to using data coming from a system, time that is actually better used to treat a patient. The other thing we are concerned is that, at least by the reading of the proposal from the 3rd of May, we believe that doctors could actually be data holders and then also obliged to feed data from their own files into research projects if this has been, or if this has been deemed correct by the authority which decides over the access of research projects. So we don't want doctors and the members of their staff to use too much time collecting data from their own data system to feed it into the European health data space for research reasons. And also, we call for the OOP, so for the once only principle, to be applied. So no data should have to be put into the system twice. Challenges, and this is something that you are obviously well aware of. There is, of course, lots of different approaches in Europe. I come from Germany, a country which is rightly ridiculed for providing or for sharing most health data using a fax machine and not using any form of digital infrastructure, not yet at least. So we are not the only ones in Germany. Of course, there are other pioneers using digital means of data exchange, like Sweden, like Finland, like Estonia, which are way ahead. But we need to find one common approach that fits all. And the other problem that we've also seen is the problem of self-certification. Another issue I'm looking forward to discussing with you. The electronic health records need, of course, to be certified in order for them to be safe. How should that be how should that be done? Is it possible to do it by self-certification? Should it be done by a certification authority like medical devices? A thing that we are not quite sure, and that we are looking forward to getting feedback from you who are who have lots more expertise in this field, if that is sufficient or not. So I think this is also my last slide. Specific challenges for doctors. Doctors will need to invest lots of money. If they want to be part of the European health data space, they will have to update their infrastructure. The question is, who pays for that? A doctor can't really be asked to invest lots of money just to be part of a health data space. That maybe doesn't even help their treatment of their patients. Doctors should not be overwhelmed by information coming from electronic health records. As I said, yes, some information is better than no information, but too much information can be also dangerous as well. So we have to find the right balance between enough and too much. Who is ensuring that the data quality in the clinical file is high enough? So does it have to be a doctor feeding data into the file? Can it be someone else? If yes, what is the qualification of this person? And this is the last point, doctors should not be overburdened by feeding data into the system. Again, doctors are supposed to treat patients, and if too much of their time is occupied by coding, by feeding data, this is time lost, especially with a health workforce which is declining in numbers. So another problem we have at the moment, if a declining number of health health professionals is combined with too much work that doctors have to put into the coding, into feeding data into the system, we have an effect we don't really wish for. I think I can close with this slide. Thank you very much for your patience, and I'm looking forward to discussing your questions with you afterwards. Thank you very much.
Thank you. So as we are a little bit behind on time, I think we can use the last couple of minutes to have some feedback. I think we can invite all the speakers on the stage to address some questions on EHDS. So I would kindly invite everybody that is at least still here. I don't know if everybody's here. I see Clara and Marcello at least. Christian also, of course. If there are questions from the room, let's go there. If there are none, I can see Lapo, so maybe we can get a mic to Lapo.
Now it's on. Yes, it's on.
It's on.
Yeah. Okay. No, I just call this silly question. I heard about cross-border exchanges, right? So you seem to imply that the problem is that there is not much connection, or the countries are not aligned, there are waves in doing this. Is that the only problem arising from the fact that we have, not such large exchanges of prescription and patient summaries? Is the citizen and patient aware of this capability? Is the users also aware of this capabilities? I mean, I don't mean if I am a citizen, I'm traveling to Paris, for your example, Marcello, and I don't know, I cannot use it, or I cannot leverage that capabilities. Although France and Italy, maybe they are connected. Is any study about this or any insight?
I think maybe I'll start and then probably it should be on. All right. It's not the only problem, of course. It's one of the questions that we're facing every day. It's that chicken and egg. How do you promote services which are not yet fully rolled out? Because then you might meet a citizen who is saying, what are you telling me that's not work? If I'm traveling from Czech Republic to Greece, it's not working for me, even though you were advertising. So we might meet disappointment. On the other side, how do you tell the patient or tell the citizen that such cross-border services are available? The promotion is, or promoting or the marketing of the services is mostly on national level, so it depends on the member state because they know their environment, they know their citizens, they know what is the right time to start advertising those services according to the level of implementation, also what are the possibilities. Also partial marketing is done on the commission side, but it's mostly on the member state side. But yes, it's a problem on how to balance this very well, not to meet disappointment or high expectations, but on the other side, be able to deliver what you're promising. We hope that, when you remember that timeline, that by 2023, 24, 25, we will be able to promise better services, or maybe by the time EHDS comes around, we will see. But it's a challenge.
And okay, numbers. E-prescription exchange until Q1 this year are 63,000.
Thank you.
Is not a small number. The highest number is between Finland and Estonia, and you know why? Because there are cross-border people working here and there, and in Estonia are cheaper. Okay, so there was a strong import. And what you say was taken into consideration access time to have a common picture, a common advertising, a common communication to citizens that it's their right to have cross-border service. Is not our duty or our willingness to implement. So yes, Clara said, we are a little shy as member state to raise a political attention on something on which we are not ready. So we have to grow smoothly and also consider what was suggested by hotel owner at the time to advertise through booking.com and everything, this right of the patient that we are ready to provide the service. So technically we are improving, practically we are growing, and then we have to liaise with other stakeholders in order to make it a reality and not 1,000, 60,000 and continue with a huge number.
Was there another question?
I can just add to this, assuming yes, it works. We are working for the future. Everybody, you mentioned Booking.com or you know, the banking service, everybody thinks the world should work like this, but for the healthcare industry, if we are honest, I don't know about every country in Europe, but I suppose it's the same in Italy like in Switzerland. You have perhaps a national e-health project to share e-health data between hospitals and doctors, and it's not in place yet. So we are working on it. It will take ages, but the important thing is that we are working on it. And one of the deliverable, which is absolutely necessary, is common standards. And the doctor said it's, there are two things. The common standards must be there, and the common standard must be used or mandated. And in the e-health data space, if I'm not wrong, the word standard in terms of international standards is not in it. It's a big mistake, and I think we have to advocate the use of international standards. I'm not selling the standards, so I don't care really, but I think it is the value for us. And we can speak endless about that, but that will take time to change to the international standard.
There were other questions? Yes, or maybe we can...
Alexander Schanner from IHE Austria. One half of my question is already answered about the number about the e-prescription. Do you have numbers about patient summary? And the second question is, do you know the reason about the low numbers? Is it on the application of the consumer side in the other country? Because Stefan mentioned in his presentation, it's absolutely necessary to have a deep integration in the native documentation system of the physician. Is this a reason maybe?
So the number of patient summaries should be about 6,000. I want to mention and advertise a page from the European Commission of the KPI. It's an open page where you can go, I don't have by heart, but we can share this. And it is a page where several KPI are connected, how many transactions, how many e-prescription, how many patient summary, how many. And we're also trying to include their concept of the quality. Why so few patient summary? Because patient summary is not implemented at member state level. And of course, we have clinical document that can be exchanged. So now the process, Christian said, we have a standard, we have the European standard, we have the international patient summary standard, and we're really waiting that member states are using. And sorry if I'm not in agreement with one of your two statements from your presentation from remote. You're suggesting to remove the tacit consent. The need of an explicit consent has been until now one of the showstoppers. And thanks to COVID, sorry if I say this, some showstopper has been removed. So now electronic prescription, even in Italy, is really electronic. We don't need a sheet of paper. And in the reality, we have to educate citizen and patient on their right and on their duty. If we are waiting that explicit consent is given, nothing will work. We have to empower patient, empower health professional to explain that things will happen unless there is the opt-out from a patient. Because if we continue working with the opt-in process, we will not go anywhere. And sorry also to say another showstopper. And the other showstopper is something that physician and even you didn't ask today, two things. Usability for health professional and change management. for health professional, because if we develop systems that are to which doctor has to be adapted to use, they will use not so well. And if every time there is a change, they have to retype all the data, you will get crazy. So in your presentation, I suggest you to add these 2 points, user-oriented services and change management to guarantee seamless transition from one system to another system. Thank you.
And going back to your question, it's definitely one of the challenges, the usage of patient summary also on national level. But from practical point of view, if we waited, or if a country waited every time until patient summary is fully implemented on national level and then went into cross-border services, that would take too long.
One additional question. The patient summary, is it a medical product according to the medical device regulation?
I don't think so. No, I
don't
think so.
We made this experiment a long time ago.
No, because
she was younger.
Marcello,
No, I tell
the
you.
patient summary.
I heard about it.
It's an architecture. It's not a software. It's an architecture, IPS. It's not a software. The software might be a medical device, but the IPS as such is not.
In several member states, patient summary is not created by a health professional, but is automatically derived by retrieving data from several systems. In that case, it becomes a medical device. I don't think so. But at the end, the fact that a document, yes, but anyway, the process that was applied in Spain now is applied in most of the member states, in which several sources are used in order to retrieve. It is under the medical device regulation. Of course, the patient summary as a piece of paper is not.
Yeah, you know, I think we are just moving out of the core topic of this this session, because we have political issues. Opt-in, opt-out, this is political. The consent is political. And now, is it UDI or not? It's not political, but it is not in our core business, actually, to decide if it is or not.
Maybe it is in our core business, because on the legal standpoint, we are always discussing if we have to apply this part of the regulation.
But it's not part of this session. This is what I mean.
Other questions from the group that were there, or maybe a response from online?
Yes, not so much response, but I basically have to echo what I heard before. Yes, we do have, I mean, regarding it, the question opt-in or opt-out. Yes, we have lots of member states, and they all have different traditions. If we were to use the European Health Data Space regulation to change the opt-in, opt-out rule in the member states, I think this will be a slippery slope. I think it will be politically impossible to get the regulation through Parliament and the Council if this would be basically an impulse to change national laws in this directive, in this direction. So I suggest that we maybe leave this untouched and just try to find a way how we can use opt-in and opt-out member states and make them available for the health data space. Again, we as European doctors support the idea of a health data space, and I think we need to get it working.
Thank you. Other questions in the interest of time? I think there was one. Yeah.
Maybe this question will be addressed more to Clara, because I'm Katarina Pretner, IHE Czech Republic. You are discussing opt-in, opt-out. We are very, very far from this, because in Czech, no national e-health is implemented yet. Very, very far from the discussion about a patient summary. But me as a patient, even if I would like to maybe share my patient summary cross-border, I'm not the one who is deciding. I would like to ask Clara, how many hospitals, because in Czech it works in the way the actually provider of the healthcare is the one who has to share the data. And how can I, as a patient, decide I want to share my patient summary? Do I have to find out in which hospital is my patient summary stored? Where is my data? Then go there and say, hey, implement it, somebody has to pay it. So how many actually healthcare providers for at about 200 hospitals and a lot of practitioners is sharing patient summary in Czech Republic?
Yes, this is a national problem, and as I said, different data quality is different in many member states. Also, the existence of data we don't know, especially in Czech Republic, we don't have central repositories, so we don't know where the medical documentation is. In Czech Republic, at this point, we're able to connect. We have connected, I think, 8 hospitals. More hospitals are going on board, and it's more or less a technical connection. Obviously, all the hospitals are not able to share all information. So that's why we're a bit hesitant with the promotion on national side. We're waiting for a better rollout of the services, better involvement of healthcare providers to be able to provide the information. And yes, it's a national problem. Czech patient doesn't know where all his medical documentation is. That's why we're creating the patient summary on the fly, collecting the patient summary, the most recent one. It's not ideal. We're not saying that it is, but it's the least that we could do at this point, unfortunately, with the status quo in the Czech Republic.
So do I understand right that actually the last data which will be delivered from my patient record, they will be actually considered to be the actual patient summary?
Most recent data.
Okay, thank you.
All right, that actually concludes our time. So unless there are any pertinent questions, I think at least the people in the room are very hungry. I don't know online whether that was already the case. Then this only leaves me to thank our, at this moment, 3 speakers, which we'll do in practicality.
Beautiful. Thank you very much.